So the statistical design of this study was a randomized phase 3 design that was designed to look for a clinically meaningful and statistically significant improvement in overall survival. Early in the pandemic, the standard of care systemic therapy did change for patients with hepatocellular carcinoma from sorafenib to immunotherapy options, atezolizumab and bevacizumab, and now more and more options are becoming available for these patients. So since that standard of care changed, we did close the study earlier than anticipated, and with minor modifications, the most obvious being that there is a lower power to detect a difference, have read out the clinical outcomes now. And those are the results I am presenting at ASTRO, the first report of the primary endpoint and secondary endpoints of progression-free survival and adverse events at the meeting. So there were 193 patients randomized, 177 who met all of the eligibility criteria, and approximately 3/4 of those patients had macrovascular invasion. So very advanced patient population group. The median tumor diameter was approximately 8 centimeters up to 19 centimeters. A small amount of extrahepatic disease or cancer was also permitted. So these are patients with very advanced cancers, up to 5 foci of HCC, where systemic therapy is the standard of care. So the outcomes of the study are very exciting. So there were clinically meaningful improvements in all endpoints. So the improvement in overall survival was impressive, with a change of median overall survival from approximately 12 months to 16 months in these patients, with a hazard ratio of 0.77. And that 16-month median survival is impressive, even in the era of immunotherapy, especially considering many of these patients were treated before immunotherapy when sorafenib just came out. And when we considered the known prognostic factors, patient performance status, the liver function, whether there was metastases or not, and the degree of vascular invasion, that overall survival remained important, with a hazard ratio of 0.72 and statistical significance with p.042. So very nice to see that improvement in overall survival. And it did appear to be somewhat more marked in patients with more advanced disease, i.e. those who had main portal vein or main right-left portal vein invasion. And although looking at subgroups is hypothesis generating, and that was 112 patients who had that degree of major vascular invasion. And in that particular subgroup, the median overall survival benefit was very marked. So from 8.8 months with sorafenib alone to 28.4 months with sorafenib and SBRT. So consistent with our prior hypothesis that these patients are challenging to treat, they often don't have a response to the systemic therapy of sorafenib or other tyrosine kinase inhibitors. And if a therapy like radiation could be used and open up the vessels, then those patients may go on to have survival benefits. So in addition to overall survival benefits, there were very important differences seen in progression-free survival and time to progression as well. There was the median progression-free survival improved from 5.5 months to 9.2 months, and the time to progression more than doubled from a median of 9.5 months to 18.5 months. And fortunately, when we looked at adverse events and toxicity, there was no change in adverse events with the addition of SBRT. Specifically, all GI bleeding events were similar in both arms, 6% in sorafenib arm, 4% in SBRT in sorafenib arm. And this is likely because symptoms occur from patients' cancers that progress, their cirrhosis, as well as their treatments. And it's very challenging to sometimes distinguish what is occurring from what. So if we have better tumor control, and specifically better control of the vascular invasion, hopefully patients will experience less clinical events. So yes, very happy to see improvements in all of our outcomes that we studied without increased toxicity.